So welcome to the talk on the elbow. My name's Henry. I'm one of the radiology registrars working at SA Medical Imaging. So the outcomes for today, again, are to understand and explain the utility of various types of imaging modalities in musculoskeletal imaging. And particular to the elbow, we're talking about fractures, supracondylar, radial head and neck fractures and olecranon fractures, dislocations around the elbow, a discussion of a few fracture dislocations like Galleazi and Monteggia fractures, and discussion of elbow joint replacements and things like tennis elbow and golfer's elbow. We'll quickly talk about anatomy first, and then we'll talk about fractures, dislocations, and inflammatory conditions. So to revise, the elbow joint is a synovial hinge joint between the humerus, the radius, and the ulna, and there are three separate joints in there. There's the radiocapitellar joint, which is a ball and socket joint, the ulnar trochlear joint, which is a hinge joint, and the superior radioulnar joint, which allows pronation and supination. So joint capsules are contiguous between the hinge and radioulnar aspects of the joint, so from superior to the coronoid and olecranon fossae to past the proximal radial ulnar articulation, and is synovial, as we've mentioned. There are medial and lateral collateral ligaments and three major bursa, the subcutaneous, intratendinous, and subtendinous olecranon bursa. So an AP radiograph of the right shoulder, we've got the distal humerus, olecranon fossa, which accepts the olecranon of the ulna, medial and lateral epicondyles. We've got the radial head and neck. We have the ulna here and the coronoid process. And on lateral radiograph, again, distal humerus here. We have the olecranon, which slides into the olecranon fossa. We have the coronoid process, which slides into the coronoid fossa, radial head and neck, radial tuberosity, and the ulna. So it's important to look at the alignment about the elbow, more important, or particularly important, I should say, in paediatric populations. And there are a few lines that we talk about around the elbow. There's the anterior humeral line, which is drawn on the anterior surface of the humerus, which should intersect the middle third of the capitellum, and the radiocapitellar line, which is drawn down the neck of the humerus and should also intersect the capitellum, which could, and if there are abnormalities in these lines, you can think either a supracondylar fracture or a radial head dislocation for the anterior humeral line and radiocapitellar line, respectively. So pediatric supracondylar fractures often occur as a result of falling on a hyperextended elbow, and often we can't see a distinct fracture line. So we look at things like the Sale sign, posterior fat pad sign, and the anterior humeral line. Like I said before, the anterior humeral line should intersect the middle third of the capitellum. Whereas we're seeing here, if we draw a line down the anterior surface of the humerus, it does not intersect the capitellum, which would be consistent with a supracondylar fracture. We can also see that there's an elevated anterior fat pad and posterior fat pad, but we'll have a chat about them in a second. And then radial head dislocations. So looking at the radiocapitellar line, we can see here it's grossly abnormal, where we draw a line down the radial neck and does not even get close to intersecting the capitellum. So we're thinking a radial head dislocation here. So we briefly touched on this. We look for indirect signs of injury around the elbow as well. One of those is an elbow joint effusion. In the setting of trauma, an elbow joint effusion suggests a fracture, which might otherwise be radiographically occult. There are a few fat pads around the elbow, and on a lateral radiograph we can see usually the anterior fat pad, but it's not normally displaced up like this. It's usually just a line that's sort of perpendicular to parallel the humerus, and usually we don't see a posterior fat pad. If we see those fat pads, so if we can see the posterior fat pad, and if the morphology of the anterior fat pad changes to look almost like a sail, which it does here, we're suspicious that there's an elbow joint effusion, and in turn should be suspicious for a fracture if we can't see one, but we can see here a fracture of the radial neck. In adults, it's usually a radial head fracture or a radial neck fracture, and in paediatrics, it's usually a supracondylar fracture. Radial head fractures may be subtle. We can do dedicated radial head views to see these fractures, and we can see here there's a subtle cortical step just there. Another example of a radial head fracture, which is not particularly easy to appreciate on either the frontal or the lateral projections, but again we're seeing elevated anterior and posterior fat pads with a sail sign of the anterior fat pad. We look here, we'd be suspicious that there's a fracture of the radial head here. Radial neck fractures are more commonly seen in children and as the result of a fall into an outstretched hand with a valgus stress at the elbow. There are other associated injuries in approximately 50% of cases, whether that be medial epicondyle, olecranon, or proximal ulnar. And we should always be looking to see that the radial head intersects, or a line drawn down the radial neck intersects the capitellum. So here we can see a Salter-Harris type 1 fracture of the radial neck and an associated avulsion of the medial epicondyle. Olecranon fractures are most commonly due to direct trauma and are often complex, or at least comminuted, and associated with other fractures around the elbow, like a radial head fracture or dislocation. We've got a comminuted intra-articular fracture of the olecranon of the ulna here. Here's another comminuted, displaced, angulated fracture of the olecranon, and with dislocation at the radial head. We draw a line down the radial neck. It's not intersecting at all where it should be with the capitellum. In paediatric populations, it's important to know about the elbow ossification centres, and it's less important to know exactly what age that they occur, more so what order in which they occur. I think most of myself and my colleagues would use the acronym CRITO to discuss the order of ossification around the elbow. CRITO being capitellum, radial head, internal or medial epicondyle, trochlear, olecranon, and external or lateral epicondyle. If we're not seeing an ossification centre that we should be seeing, for example, if we're not seeing a medial epicondyle when we have ossification at the trochlear and olecranon, we'd be suspicious that this is fractured and displaced. And that's exactly what we've got here. So we can see we've got C, we've got R, we don't have I, we've got T, we've got O, and we've got E. So we've got all of the ossification centres, except we're not seeing the medial epicondyle or the internal epicondyle, which suggests that this has been avulsed or fractured off, and we're not seeing its position on this radiograph. So it's critical to know the order of ossification centres when we're looking at a paediatric elbow. Not only is it can it be displaced, but it can also mimic another ossification centre. So you can have a medial epicondyle that looks like a trochlear. And it's important to pick up because if we don't diagnose them, they can lead to long-term significant disability, and occasionally will need open reduction and internal fixation. Elbow dislocations are the most common dislocation in children, and often in sporting injuries. The aim is to reduce to minimise the likelihood of neurovascular compromise. You can have posterior, which are the vast majority, anterior and divergent dislocations, and radial head dislocations, which we've already discussed, often associated with fractures as well. Here we've got a posterior elbow dislocation where the radial head and ulnar, olecranon of the ulna, are displaced posteriorly to the distal humerus. This can be as a result of fall onto the outstretched hand while the elbow is in extension. The coronary process is dislocated from the trochlea, and you've got risk of neurovascular compromise to the ulnar and median nerves and the brachial artery. It can be associated, of course, with distal humerus fractures, radial head fractures, and coronoid fractures. Anterior elbow dislocations are usually as a result of a direct blow to a flexed elbow and can be associated with Olecranon fractures as well. We see that the radius and ulna are displaced anteriorly compared to the distal humerus. Divergent elbow dislocation is more rare. We've got disruption of the proximal radio-ulnar joint with the distal humerus between the radius and ulna, which dislocate in two different directions. You can see here we've also got a mid-shaft humerus fracture as well. And radial head dislocation, we've talked about before. The line drawn down the radial neck does not intersect the capitellum, mainly in a paediatric population as a result of a fall on an outstretched hand, and really think about its disruption of the proximal radio-ulnar joint. So radial head subluxation occurs in the paediatric population with a peak age of 2 to 3, where the radial head subluxes under the annular ligament, which usually attaches it to the ulna. Usually as the result of a pulled elbow or a sudden pull on a pronated and extended arm. The patient will usually present with their elbow flexed in a prone position. Actually, like I said, clinical presentation is a patient presenting with the elbow flexed in a prone position and unwilling to supinate it. And the use of imaging is sort of unhelpful because it may be normal and it may be reduced during positioning for imaging anyway. Moving on to talk briefly about fracture dislocations. There are three main ones around the elbow and forearm. Galleazi fracture dislocation is a fracture of the radial shaft, classically at the junction of the distal and middle thirds, with associated dislocation at the distal radio-ulnar joint. So here we can see that there's a fracture of the radial shaft, and on our lateral projection we've got disruption of the distal radio-ulnar joint with dorsal dislocation of the radius, and usually occurs as a result of a fall on an outstretched hand. A Monteggia fracture dislocation is a fracture of the proximal ulna, or proximal third of the ulna, with dislocation of the radial head. It's usually as a result of a fall on an outstretched hand with pronation, and we see here that there's a fracture of the midshaft of the ulna, and if we draw that line down the radial neck, it does not intersect the capitellum, suggesting that there's a dislocation at the proximal radio-ulnar joint, or the radial head is dislocated. And an Essex-Lopresti fracture dislocation is where there's a comminuted radial head fracture and a distal radial-ulnar joint subluxation or dislocation. Another pathology that occurs at the elbow is ulnar nerve entrapment. So the cubital tunnel is where the ulnar nerve travels posterior to the medial epicondyle of the humerus, and patients with compression or entrapment at this point present with altered sensation in the 4th and 5th digits, and with progression you can have sort of marked wasting around there. Different etiologies with overuse or subluxation of the ulnar nerve from congenital laxity or compression from any number of things. Here, proximal, we're seeing a normal ulnar nerve. Then we have an area of compression on ultrasound that we're seeing in that cubital tunnel, and distally that nerve is more hyperechoic. Lateral epicondylitis is, or known as tennis elbow, although not usually seen in tennis players. It's overuse and chronic repetitive stress to the common extensor tendon, which is located at the lateral epicondyle. It can lead to partial tearing at this tendon and tendinosis, typically involving the ECRB. Can progress to a full thickness tear in more severe cases. On MRI, we can see that the common extensor tendon originates at the epicondyle, normally has a low intensity on T1 weighted imaging, but in tennis elbow, we can see both thickening and abnormal high signal on both T1 and T2 weighted imaging at the common extensor origin. Medial epicondylitis, or golfer's elbow, is the equivalent of tennis elbow, but medially, so it's overuse or chronic repetitive stress to the common flexor origin, which is at the medial epicondyle, again leading to partial tearing. And the findings are similar on MRI, so this is a normal study. We can see the common flexor ligament or tendon originating at the medial epicondyle normally has low signal intensity, but in medial epicondylitis we've got abnormal signal on both T1 and T2 weighted imaging. Olecranon bursitis is inflammation of the Olecranon bursa, has a number of different etiologies, repetitive overuse, trauma, infection, or inflammatory, particularly gout. And on radiographs we can see here's a big superficial soft tissue swelling, and ultrasound I think will be more helpful, which can show us fluid collection in the Olecranon bursa. A brief discussion on some of the arthritic changes around the elbow. So osteoarthritis, and the typical findings of the elbow are, or sort of anywhere, are destruction of cartilage, which you'd see on MRI. You've got joint space loss. You can have subchondral sclerosis, which means below the articular surface, below the cartilage, we have sclerosis and the formation of osteophytes, which we're seeing, say, here. Rheumatoid arthritis is an erosive arthropathy. So we've got here, we can see that there's extensive erosive change at the olecranon. Gout is another erosive arthropathy. Here we can see there's deposition of gouty tophi in the soft tissues. Like I said before, can be associated with Olecranon bursitis as well. And a brief discussion on elbow joint replacements. Indications include osteoarthritis, including post-traumatic arthritis, rheumatoid arthritis, severe fractures or instability, and we can either have a total joint replacement or a radial head replacement, which we're seeing here with a radial head replacement or a total joint replacement. So that's all for the elbow. Thank you.